Everybody, right, Susan?
Hey everyone, it's a dose of Dr. Drew.
Thank you so much. I'm in a hurry because I want to get right to our guest who very kindly stepped aside from his clinical work to give us a report on some of his observation. Is Dr. Vladimir Zelenko. We're going to talk a little COVID and a little hydroxychloroquine. I see you guys on the chat and the restream. I will get to you. Sound is no good again.
It's the sound mini ad. It's not syncing, but that's okay. This is
they
more
hear
important.
me nonetheless. They're saying they hear me. So, Dr. Zelenko, before we get into the clinical stuff, it just occurred to me we share a heritage, and before the mics heated up, I was saying how my family was part of the diaspora of the turn of the 20th century from your region of the country or the world. And maybe you can answer this for me before we talk about COVID. No one has ever been able to explain to me what that diaspora really was all about. Why did everybody leave? Particularly all the Jews, get up and leave all of a sudden? Is there some history I should know?
Well, yeah, you know, the essence of all Jewish events is they tried to kill us, we won, and now let's eat. So we had to escape from being killed so we can eat in an affluent way in America.
But was it the Bolsheviks, or who was the problem? Because I found out recently my grandfather was a sergeant in the Russian army, and I thought that does not fit this running away thing that I've always been told about, which my grandmother propagated. She was scared of the bandits, and I don't know if she was talking about the Bolsheviks or about just some other. There were a lot of roaming groups, I guess, at the time.
It probably was the Cossacks when the Tsar was still around, and then when he was overthrown, it was the communists and the Bolsheviks, right? So it wasn't good all around.
So it was Fiddler on the Roof or Lenin, one or the other. So okay, let's get into some real stuff here. You have some data. You've been at the tip of the spear, as you've said, in the COVID fight, and you've published some information about the use of hydroxychloroquine. I have used that medication my entire career for rheumatic conditions, never seen even close to a side effect in spite of years of use, daily use, and occasionally would send people to an ophthalmologist. Now, back in my day, 10 years we'd worry about a retinal phenomenon. At 1 year we'd worry about at corneal deposits. Never saw any of that. And then suddenly all this concern came out about this medication being dangerous, which was stunning and bizarre to me. I came to understand its antiviral effects, which are protean, so it looked like a good, idea to try this drug. And evidently you thought so highly of it, you did a study.
Right. So first of all, I have some tremendously good information, optimistic information to inform the American public. There is an effective approach in treating and managing this terrible infection, and we're going to be able to convert this infection into a similar disease like influenza. Let me explain what I mean. I use a 3-drug regimen and the most important part here is zinc. Zinc is the virus killer.
What dose?
I use zinc sulphate 220 milligrams. It's basically you need 50 milligrams of elemental zinc.
Got it. So essentially what you get in the health food store.
Correct.
Yeah.
Now, the zinc has trouble getting into the cell because zinc is a positive ion and it doesn't cross the lipophilic cell membrane. So what hydroxychloroquine does, it's ionophore. It opens a channel and allows for zinc to into the cell. That's where the virus is, and that's where the enzyme called RNA-dependent RNA polymerase or replicase is. That enzyme is essential to viral replication. So if you inhibit that enzyme, you inhibit the viral load.
If you don't mind, I'm going to ask questions as it occurs to me along the narrative here. And does that suggest we should all be taking zinc on a daily basis, and then if we get sick, add in the medication that lets the zinc work better, or is there no use to zinc on a daily basis without the other medicine?
Well, the data shows that over 40% of the adult population is zinc deficient. So that actually is contributing to the morbidity and mortality. So we all should have a normal amount of zinc in our systems. And if we are exposed to high viral loads, like physicians or people in the front lines, we should be taking supplemental zinc. However, you needed to take it with a zinc ionophore. And there are a few available, actually. Hydroxychloroquine is just one. There is something over the counter called quercetin, which does the same thing.
Quercetin?
Querce.
Oh, yeah, I've seen that. Okay, interesting. Is there any adverse, I've got it up. Is there any adverse effect of that medication or that supplement?
Not that I'm aware of. However, there's not enough data for me to outright support its use. So I've limited its use to prophylaxis or as plan B when patients cannot get access to hydroxychloroquine for political reasons.
It looks like a plain old polyphenol, so it might just be an antioxidant. So I see no strong. I'm going to get some, frankly, myself, because I take a little zinc on a daily basis. It nauseates me. But I've been convinced by the zinc data all along. But I have been concerned about this very issue. So this is very interesting to me.
Let me give you an analogy. Think of hydroxychloroquine or quercetin as a gun, and zinc is the bullet.
Mm-hmm.
You need both. A gun without a bullet, or a bullet without a gun is ineffective. But when you combine the two together, you can deliver the virus killer into the right place.
Susan, I'm getting you some too.
The antibiotic serves as a vest that protects the patient from developing secondary infections.
I don't like that explanation so much, because that would mean we should be using antibiotics every time somebody gets a viral illness.
No, I'm talking about specifically COVID-19.
Specifically for COVID, okay. And is it 500 milligrams of the quercetin, or the 250, or the 1,000? Do we have any idea what dosing?
Yes.
Which?
Yeah, I use 500 once a day for prophylaxis, and 500 BID twice a day for treatment.
All right, tell us about your data.
My data shows the following, that let me describe to you what's been coined as the Zelenko protocol. I use 3 unique steps in my approach, which then I will report the data on that. So I risk stratify patients, and I only treat the high-risk patients who have a 5 to 10% mortality rate.
And how do you stratify to that group? Is that numbers of risk factors, or?
Anyone over the age of 60 with symptoms,
mm-hmm.
anyone under the age of 60 with comorbidities and symptoms, anyone that looks toxic in my office, regardless of age.
Got it.
Because if you look in the hospitals, those are the patients dying.
Yeah.
So, right. So the rest of the patients all recover without any medical intervention, just
right.
supportive care. So I choose to intervene only in the high-risk patients, as I mentioned.
Got it.
Even more essential to that, I begin to treat within the first 5 days of the onset of symptoms based on clinical diagnosis, even before confirmatory testing.
I can see no reason not to. And by treating, you don't mean the zinc and the quercetin, you mean the Plaquenil.
Right. I use zinc, hydroxychloroquine, and azithromycin within the first 5 days of the onset of symptoms, even before I get the results. And I'll explain to you why. Because if you look at the viral load dynamics, it's relatively constant until day 5. Around day 6, the viral load explodes.
Yeah.
And that's important because on average, the data shows that a patient comes to the doctor's office between day 4 and 5. First few days, they don't feel well. They think it's going to get better. Day 3, they say it's not getting better. They call the doctor's office. They get an appointment day 4 or 5.
Yeah.
And if you do the testing, at this point, it takes 3 days to get the results. So that would bring the patient into day 8. At that point, they're really sick. So the idea is to intervene when it makes the most sense.
I'm all for that. In fact, I read some data this morning on remdesivir suggesting that should be used earlier than we're using it for the same reason.
So remdesivir seems to be a good drug, but at this point, the data shows that it reduces inpatient stay, hospitalization from day 15 days to 10 days. So my approach is stay out of the hospital, much better for you.
People are asking what the name of the supplement is, so I'm quercetin. Telling it on the stream right now. So before you give us your data, I have one more question about other ancillary treatment. There was some pretty good studies on dexamethasone. I talked to an infectious disease, and as I read that data, I thought to myself, probably the earlier the better with the dexamethasone, but I talked to an infectious disease specialist yesterday who said, nah, we use it late, we use 6 milligrams, and we only use it in the ICU. And I thought, wow, seems like that's not going to do very much by that point. Do you have any opinion on corticosteroids?
I do. There are 3 stages here. There's stage 1, which is the outpatient stage. Stage 2, when the patient's getting sick and they need to go to the hospital. Stage 3 is the ICU stage. It would make sense most use steroids when the inflammatory component of the disease is present, which
Yeah.
is at the end of stage 1. So the idea is to intervene as quickly as possible so that they don't need the steroids.
Right, right. Now, I've noticed, you know, now we have these 6, if you saw that New England Journal article where they identified 6 genetic groupings that associate with adverse effect of this thing. And it, you know, is involved with the cytokine system, and it probably has something to do with metabolism also. It also involved the blood types, which I found fascinating because I'd been denying that the whole way, and it turns out I was wrong about that too. I myself have always noticed when I get bad viruses, I become incredibly toxic incredibly quickly. And the one time when I was a kid, I mentioned to you my dad was a family practitioner, they put me on steroids. It was a bad infectious mononucleosis, which is a specific thing, but I would say that it's a very familiar syndrome for me with viruses. I got better like that. Are there certain subgroups, do you think, genetically, is your hunch? I know we don't have the data on this yet, that there's certain subgroups that maybe are more prone to the cytokine activation and maybe more likely to benefit from things for general immune suppression, like a corticosteroid?
I don't know if it's the cytokine issue or the hypercoagulation state that is induced by later stages of COVID-19. So I would say that the role of anti-inflammatory medication needs to be custom tailored to patients that are prone to having uncontrolled inflammation. So as you know, anticoagulation issues cause inflammatory problems as well. So
yeah, that's all related.
My point is treat the patient so early that they never need to manage side effects or complications.
Well, I got to tell you, the one case I got early, I don't want to violate any HIPAA thing here. Let me just say that there was a family that got sick. Within the family, there was somebody with, you know, multiple risk factors. I put him on early and it did not go well. Did not go well. I put other people on early too, and it did go well, but one time it didn't with multiple risk factors. So Andrew Alkashvili is a viewer of ours who has been very helpful for me, and he hooked me up with you, and he's asking, how many countries have contacted you and are using your protocol?
7.
7 countries.
I've advised, go ahead, I'm sorry.
Go ahead, you've advised?
Israel, I've advised Brazil, Honduras, Chile, Ukraine, parts of Russia. There's another country, I think Guatemala.
Strange that the Western countries not so much. Weird. Or do they have a weird feeling about hydroxychloroquine in the West? It's
called death by affluence.
By specialness. Death by specialness. Go ahead and do your thing. Let me look at your, I'm looking at the chat stream while Dr. Zelenko takes care of some business there. All right, let's hear your data.
So yeah, so my data shows the following, that if you use the Zelenko protocol, as I mentioned, which is, again, I'll just reiterate, risk stratify patients, identify the patients that are going to have a 5 to 10% mortality rate, intervene within the first 5 days of onset of symptoms, use zinc, hydroxychloroquine, and azithromycin or doxycycline, it's up to you. I showed an 84% reduction in hospitalization compared to a control group of patients that were positive, PCR proven positive for COVID, but did not receive the treatment. And I had a 99.7% survival rate of my patients.
And was there anything different? Have you published this yet?
It's been submitted for peer review, and we're letting it out in preprint.
Were there anything different in the two populations? Is there anything that as you go through peer review that they pointed out that way?
Actually, no, because I'm a doctor for a community of 35,000 people, and I also manage the EMS system. So I actually knew every single patient, why they went to the hospital, how long they were there, what was their diagnosis, and those that died. So I was able to compare apples to apples.
So what do you think, and by the way, there's another, as I mentioned to you, there's another study that came out this morning on the use of hydroxychloroquine that looked fairly promising out of Michigan. It's from the International Journal of Infectious Diseases. It looks good. In fact, they had improvements with all hydroxychloroquine protocols. I haven't read it carefully yet, but that's what it looks like to me. And why is science getting encumbered by politics? I mean, it's going to kill people if we're not careful.
So people are not dying from COVID-19 anymore. They're dying death by politics. And what I mean by that is that we have a very safe, cost-effective, incredibly effective treatment to manage the early phases of COVID-19 to prevent patients from getting to the hospital. And there are tremendous obstacles to access of care. And there are four components to that. There's politics, there's financial big pharma conflicts of interest, there's arrogance in the medical community, and then there's fear by physicians. And let me explain each one very quickly.
Okay.
Politics, as you know, the president came out in support of hydroxychloroquine. This is right before a crucial presidential election. If this turns out to be part of the solution, it's a big political win for the president. And there are forces, half the country doesn't want him to be president. And so they're trying, in some ways, in some circles, trying to suppress this information until after the election so that Trump doesn't get a win.
So they're willing to sacrifice people's health and the functioning of medical research and our clinical decision making on behalf of a political ends.
It's crimes against humanity. Second, you have big pharmaceutical companies that have invested billions of dollars into vaccine development and expensive medical treatments. As you see, remdesivir, it is actually an effective drug, but it works at this point in the hospital setting.
Right.
What I'm advocating, and my approach keeps, at least my data shows, 84% of the patients out of the hospital. That's a decrease in their market share of 84%.
Right. Right.
Number three, I'm sorry, go ahead.
Well, I was going to say, originally the Gilead gave away the medication. They gave away 1.5 million doses, and now they're starting to charge. So you're
$3,200 a course.
Yeah, I was going to say, presently your logic applies. So keep going.
You know, my approach costs $20.
Yeah. No, listen, I've used it. Trust me. I have used it to good effect, in my opinion. And I looked at the data. It made perfect sense to me. I didn't have a lot else good. And the data keeps coming in good for the early, not late. I wouldn't use it late in this disease, but early, it looks really good. And let's address the QTC nonsense. Literally, so the FDA keeps focusing on what you call a cardiac effect. Well, let me explain to you the cardiac effect. It's a prolongation of the last phase of the EKG when the heart is repolarizing. There's a dreadful complication when that part prolongs. It's called torsade de pointe. And there have been no cases of torsade, none, zero. So there have been no real complications. The QTC prolongation is like saying the patient has a rash. You stop the medicine, it goes away. So it's a non-issue. The only time I've ever seen it is in methadone patients who already have prolonged QTC. Of course, no one makes an issue of it with methadone, but the two together should not be used if you have somebody with a long QT. Do you disagree with any of that?
Not only do I agree with everything you said, but I will tell you that I queried the top electrophysiologists in the country. There's only around 3,000 of them, I found out. And they have a WhatsApp group. So they asked each themselves, has anyone seen a QT related arrhythmia? And the answer was no. Here's the caveat: in the outpatient setting. In the ICU setting, they have seen it. However, there it's hard to know because COVID-19, 30% of the patients develop cardiomyopathy. So
right.
We don't really know what's causing it. But the point is, in the outpatient early phase, stage 1 of this infection, there's been zero cardiac complications.
Right. And because we don't know quite what's going on late, we all agree we don't use it late. But let's be fair. Every case I've seen where there's a cardiac death with COVID, it's a myocarditis. I mean, it's profound. I mean, that happens. And so, of course, they get arrhythmias. Of course.
Listen, it's much easier to put out a small fire than a big fire. So if we intervene early, we'll prevent all these. These have become moot points, a non-issue.
And so keep going through your list. I got through the political part. I think it's about as far as we got. The 4 reasons for allowing people to die and not get proper treatment.
In the beginning of this year, the New England Journal published an absolutely horrific article where they concluded that only clinical trial data has any validity, and anecdotal data or empirical real-world evidence is not to be used to set medical standard of care.
And Dr. Zelenko, both you and I are old enough to remember a similar admonition that we received almost verbatim. And any of the rest of you who are younger physicians, I will just use 3 words: Women's Health Initiative. We were told we were witch doctors if we didn't adhere to the findings of that study, which turned out to be bogus. Remember that?
Yeah, sure, I remember. But I have a little statement here.
Yeah.
I would rather be empirically or anecdotally alive than academically dead. What I mean by that is, while I do support clinical trials, they take time. And that's one thing we don't have a luxury in the World War III global pandemic situation. So it would make sense to use the best available information in parallel with doing research. And we'll use the best bullets that are available now. If something better comes along, we can transition to that. But to wait and tie the hands of physicians on the front lines because you want to invalidate, because of the arrogance to invalidate real world experience. You know, human history has evolved not through clinical trial data. It evolved through trial and error and empirical data. You know, if I'm in the middle of the ocean drowning and I see a piece of driftwood, I don't need a clinical study to tell me that I should hold on to the driftwood. I may get a splinter, that's true, but at least I won't die.
And by the way, to be fair to our peers, most of them have actually been using these things. We've been using these empiric approaches to good effect, which is why we keep using them. And by the way, giving them to ourselves and our family prophylactically. I know people are doing that. So here you go.
Any smart doctor I know is actually prophylacting themselves or their families, or at least has a stash for themselves.
That's been my truth. That's been what I've found as well. So keep going. That's 2.
That's 3, actually.
3. Okay. 4.
4 is fear of physicians. This has been so demonized, and there's so much fear of retribution and litigation and losing your credentials. It's hard to become a doctor. You invest at least 11 years, hundreds of thousands of dollars. You have a family to support, and then you're threatened that you're going to lose your livelihood if you use a treatment that's FDA approved, and you have a legal precedent to use it off-label, and yet you're being told that you can't. That creates a psychological barrier in the minds of physicians and probably in the patients because of the fear mongering. So that's a terrible propaganda.
Well, and I would argue for me personally, I saw some reprehensible behavior where our profession was being usurped by journalists and talk show hosts. I saw, listen, this is nothing against Joy Behar, but she got caught up in the frenzy saying, "Don't you understand? This will kill you." And then the entire editorial staff of the New York Times was signing directives on non-pharmacological interventions for this disease. What the hell? Did that? Go ahead.
History is unforgiving. It will become very clear very soon who was on the right side of history, who was on the wrong side of history, who was trying to advocate for human life and the sanctity of human life, and who was creating barriers and committing crimes against humanity. So it will become very quickly very evident what the truth is.
I hope you're right, because I feel like it's all there's a big fog, about, a little bit of a fog of war around this, whereby people are writing their own sense of history, and the journalists don't seem to understand what they're doing in terms of usurping the practice of medicine and driving it around non-clinical, non-scientific kinds of priorities. It's very disturbing.
It's tragic, and it's resulted in hundreds of thousands of deaths unnecessarily worldwide. And I've seen it firsthand. I've been on the front lines. I've consoled family members of people who died that did not need to die, and it's heartbreaking. And that's why I've been so vocal about it.
How would you characterize I know you've got limited time here, so I'm going to keep you about 5 or 6 more minutes, but how would you characterize the outbreak now and our response to it? Do you have any opinion about that? Other than the pharmacotherapeutic piece, just sort of how the governors are doing, how we're doing, where we are with it. Where are we?
I think it's better. I think the understanding, just common sense, that you have to treat an illness sooner than later is taking hold.
Yeah.
A lot of quiet off the radar physicians just doing the right thing. They don't want the publicity and they don't want the headaches of under scrutiny. The public, not everyone's as insane as I am, who basically opened themselves for worldwide abuse. But nevertheless, so I think it's better. I think there are some logistical problems that I don't think this country has enough drug in enough places so that every patient in this country who needs it gets it in the right time frame, and that needs to be fixed. And it takes political will. And I think that if the standard of care is changed to the approach that I'm advocating, you can literally open up the economy today. Because this infection should be approached like every other infection and be managed. I didn't say it was a good infection, but nevertheless, we can reduce deaths significantly enough that more people are dying from the closing of the economy now than
I'm aware. I'm aware these diseases of despair are skyrocketing. So I want to circle back around to where we are now. It's largely younger people presently getting the infection. Shall we be treating them in a similar manner?
Absolutely.
Or is there or because they're low risk, are we just letting it play out?
Absolutely, they should. The only way you can get through this infection is to get it and overcome it. Your immune system has to overcome it. If you're young and healthy, this infection is less dangerous to you than influenza.
Right. Say that again, because people become infuriated by that statement, and I don't know why. Go ahead, say it again.
Flu A and flu B, infected, I believe, 40 million Americans last year, and that's with the flu shot being available. And out of those 40 million, around 50,000 died. And out of those 50,000, many of them were young children. If you look at the statistics of COVID-19, the young are spared, almost 99.9%. So
right.
If I have children, thank God, I would rather them have COVID-19 than influenza.
100%. And so to that point, people on my chat stream are asking, should we be opening schools sooner, given that influenza infects children, harms children, it's transmitted by children, and COVID is none of those things?
We need to reintegrate back into society, live as normally as possible, and deal with the challenges as they come along. We need the appropriate political will that does what's best for its citizens, and that's not decisions based on politics and economics. And we need access to these medications in every pharmacy, and every doctor has to be informed that you are free to use this medication to save your patients.
I'm going to let you go. You've been very kind and generous with your time. I want to cycle back one more time and ask I'm not sure I got a clear idea of where you are with corticosteroids and their use, because people are using it a lot, even in these younger patients. Where do you fall with, I mean, in other words, if somebody seems, let's say you have a 40-year-old seems moderately ill with this illness, steroids, yes or no?
Yes.
Yeah, okay. That's what I thought you were saying.
So if someone is, looks a little toxic, not fully toxic.
Yeah.
It's the art of medicine. You have
I
to
get
know
it. I get it. I just want to make sure where you were. That's sort of where my head's at with it too.
They also use anticoagulations like Eliquis and stuff because these people clot really bad and they die. So if I see someone is really going over the threshold of what I'm comfortable, I will give them steroids and anticoagulation.
With which one?
Eliquis or Xarelto.
Yeah. Aspirin too, or no?
No, I use the.
Okay. Yeah, I had H1N1 when I was 50, and you want to talk about toxic? Oh my God, that was a brutal illness, and that killed 40 and 50-year-olds routinely.
Yes. It
infected. My understanding is it affected 1 billion and killed 500,000 worldwide. And we're in an absolute panic now about 10 million worldwide. I just want people to adjust their emotions. I wish we could get our emotions sort of calibrated to our situation. Do you think there's any point to that?
I think people have.
All right, you got to go.
Let me just answer this question.
Cue.
Yeah.
I think that we need to focus on the truth of medical information. It needs to be spread without corruption. And it's so sad that what science used to represent, which is objective truth, has become nothing more than a puppet for politics and for big pharma interest.
I think that's a good drop the mic statement. Get back to your work. Appreciate you being here with us.
God bless you, Dr.
All right, thank you, sir.